So we're gonna finish the the implantology and surgery. Internal bevel incision is used for modified Whitman flap, apically positioned flap. A 2 centimeter laceration on lip. How do you stitch? Continuous. Incision on corner of lip. Where do you suture? You suture mobile first and fixed later. What is an undisplaced flap? Pocket depth reduction, gingivectomy. Apical position flap. Pocket elimination or increases width of attached gingiva. Best prognosis for apically positioned flap is 2 millimeter apical to alveolar crest. Perioflap for mandibular anteriors, lateral repositioning, or gingival recession. The least desirable place to place a graft will be in mandibular first premolar space. What location is apical positioned flap contraindicated? Retromolar of third molar, maxillary palatal. Yes, maxillary palatal and also mandibular lingual. Flap not to use for extrusion of canine. Apical repositioning flap. Flap to not use for extrusion of canine. An extrusion of a canine. What apically repositioning flap? Most likely to damage nerve in vertical release of flap. Again, most likely to damage nerve in vertical release of flap if you do a flap of the lingual. Where to avoid vertical incisions in the lingual and the palate. Incision for vertical or oblique flap at line angles. So determination of a vertical incision at the gingival crest must be at the mesial or distal line angle of the tooth. Internal bevel and replaced non-reposition flap. Internal bevel and replaced non-reposition flap, modified Whitman. Flap reflection for for modified Whitman flap goes how many millimeters beyond the alveolar crest? Flap reflection for modified Whitman flap goes how many millimeters beyond the alveolar crest? 2 to 3. Modified Whitman flap reflection does not go beyond mucogingival junction. Incision for patellar tuberosity reduction. Why? Flap for removal of palatal torus, double Y with midline incision. Y-shaped palatal incision for maxillary tori removal. Where can you not do apically positioned flap? Maxillary palatal. Distal wedge contraindication. Third molars without attached gingiva. Contraindication when using distal wedge technique. Not enough keratinized tissue. Contraindication when using distal wedge technique. Not enough keratinized tissue. Distal wedge technique when there is not enough keratinized tissue. So the incision designs for surgical procedure, distal to the mandibular second molar. The incision should follow the areas of the greatest attached gingiva and underlying bone. Again, the incision should follow the areas of greatest attached gingiva and underlying bone. Thus, the contradiction or the contraindication to use a distal wedge technique is not enough keratinized tissue. A distal wedge is limited to the formation of the ramus. Distal wedge is limited to the formation of the ramus. So the outline of a triangular incision distal to the molar, cross-section view showing a wedge removal and thick tissue. Then undermining incision used to thin the tissue, then reflection of flap for osseous correction, and then you can suture the tissue. So incision for distal wedge can be done. Okay. The distal wedge incision is triangular, which is placed creating the apex of the triangle close to the hamular notch and the base of the triangle next to the distal surface of the terminal tooth. The thinning or undermining incisions are accomplished before full reflection of tissue and are extended 2 to 3 millimeters apical to the crestal aspect of the tuberosity. Complication with distraction osteogenesis. It can be a long-term follow-up. Simultaneous increase of bone length, distraction osteogenesis. When to use distraction osteogenesis over conventional osteogenesis? Because there's bigger stable movements. Distraction osteogenesis versus regular osteotomy. Distraction osteogenesis can't move mandible posteriorly. The most common surgery for maxilla is the fourth one. The fourth one with bilateral sagittal A class 3 can be fixed by a Le Fort 1 with a bilateral sagittal osteotomy. The worst complication of bilateral sagittal osteotomy is damage in the IAN, inferior alveolar nerve. The most common surgery for mandibular augmentation is a bilateral sagittal osteotomy. The advantage of a Z-plasty technique is that it decreases the effect of scars. Z-plasty technique is used in frenectomies. Z-plasty technique, and the advantage of this technique is that it decreases the scarring. Z-plasty technique decreases the scarring. Diastema caused by frenum. Don't do frenectomy until the maxillary canine erupts. If you have a patient with a diastema
Diastema caused by frenum.
diastema,
Diastema.
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 So if you have a diastema on a patient, you will not do a frenectomy until the canine has erupted. If you have a diastema caused by a frenum. A frenectomy for a child. Wait until upper permanent canine has erupted. Image for zygomatic fracture, vortex, submental vertex, submental vertex. Image for mandibular fracture, panel. Image for condyle fracture, waters. No, reverse towns. Image for midfacial fracture, waters. Because waters will show you the maxillary sinus. So mental vertex is the image that you will use to see a zygomatic process fracture or a zygomatic process. If you get hit on the right of the jaw, what gets broken? The left condyle. If you have a fracture in the body of the mandible, other fracture will occur in the contralateral, the opposite side, not contralateral, the opposite side. So if you have on the condyle, so if you have a fracture in the body of the mandible on the right side, you'll have a fracture on the left condyle. So the angle of the condyle is the most fractured, and the angle and then the coronoid, then the ramus. Fracture to compromise patient respiration. Fracture through the body of the mandible. Most common fracture on the face, the zygo. I don't know about this one. I think it's a nasal bone, nasal. The most common etiology, okay, nasal bone, then mandible, then orbital bones, then zygoma. Yeah. So the fourth one, Gehring's sign. Okay. We're gonna go to the next information. We're gonna review resumen. The pulp is blood, nerves, and connective tissue. The characteristics of the pulp is that it is surrounded by hard tissue, thus it does not tolerate edema. It lacks collateral irrigation, so it does not cope with bacteria. And the pulp has odontoblast and mesenchymal cell osteoblasts. Pulp has odontoblast and mesenchymal cell osteoblast. What controls sensibility of the pulp? A delta fibers, which are myelinated, and they are responsible for acute pain, A delta fibers, and the C afferent nerve fibers, which are unmyelinated, and they are responsible for chronic pain. Pulpal diagnosis: normal, reversible inflammation, irreversible inflammation, and necrosis. The normal pulp is asymptomatic, mild, moderate response to vitality test, no pain to palpation, no pain to percussion. Okay, so normal pulp is asymptomatic, mild, moderate response to vitality test, no pain to palpation, no pain to percussion. The reversible pulpitis is pain quick and sharp to vitality test, but disappears as soon as the stimuli is gone. If you take the vitality pulp, if you take the irritant, pulp will return to normal. How can you separate reversible and irreversible pulpitis? Cold will cause pain and disappear, and this is reversible. Cold will cause pain and linger, irreversible. If there's no spontaneous pain, it's reversible. If there is spontaneous pain, irreversible. Irreversible pulpitis microscopy is you'll find micro abscesses of the pulp and present. Micro abscess of the pulp is present. You can still see myelinated and unmyelinated fibers in inflammation areas. Irreversible pulpitis can be asymptomatic and symptomatic. Asymptomatic irreversible pulpitis can be hyperplastic or have internal resorption. Hyperplastic asymptomatic irreversible pulpitis can be growth like a cauliflower around the cavity, and is more prevalent in young adults because they are very vascular. If you have internal resorption asymptomatic irreversible pulpitis, it can be discovered in routine X-ray, and there are chronic inflammatory cells. There will be some necrotic pulp in coronal aspect of pulp. If you have a symptomatic irreversible pulpitis, you'll have spontaneous pain, lingering pain, postural change, triggers pain. X-rays are not conclusive, maybe thick periodontal ligament, and electrical tests has no value because there's necrosis can lead to irreversible pulpitis, trauma, long-term interruption of blood supply. Necrosis can be caused by irreversible pulpitis, trauma, long-term interruption of blood supply. Necrosis may be partial or total. A periradicular disease is any periradicular lesion of pulpal origin or associated to irritants in the pulp. Signs and symptoms of periradicular disease: it can be asymptomatic or increased pain with fever radiographically, may be bone resorption, but may not be visible. Common cause of failure of amalgam restoration: moisture contamination, improper design, and improper trituration. Common cause of failure. The most common is moisture contamination. There is a fracture line on amalgam restoration. What is the treatment of choice? Redo the restoration to check the fraction of tooth. Just remove mesial side and check, and some other options. Okay. Which one appears on tooth first? Pellicle. Montelocast for asthma. One mechanism of action: leukotriene receptor antagonist.